Welcome to Concept Medicine. In this tutorial, we are going to be talking about the abnormalities of the A wave on a JVP waveform. But before we start, let's review the question that I asked in the previous tutorial session. And the question was, what name is given to the process by which a recipient tissue acquires nutrient and oxygen through the absorption of plasma via capillary action in skin grafting? And I believe we've all gotten our answers right. The answer is plasmatic imbibition. All right, congrats to all who got it right. Let's move on and talk about abnormalities of A wave on the JVP waveform. We'll start by reviewing the A wave in our previous series. That is the JVP waveform. We said that the A wave denotes active atrial contraction. Anytime the right atrium is actively contracting, it produces a positive deflection, which is recorded as the A wave. So if you look at the JVP waveform as illustrated here, the A wave is what you are seeing here. It's a positive deflection. Let's move on and talk about the abnormalities of the A wave. We'll be looking at three different abnormalities. The first one, we'll talk about absent A wave. When we talk about absent A wave, simply it denotes atrial asystole. Atrial asystole, meaning that the right atrium is not contracting. And as it's not contracting, it is unable to produce the positive wave, which is denoted on the JVP waveform as the A wave. The next thing is, what are the causes of the absent A wave? We'll be talking about three different causes. The first one is going to be atrial fibrillation. Atrial fibrillation. The second one will be post-direct current conversion of atrial fibrillation. And that will bring us to the principles of management of atrial fibrillation, which is in three steps. We have the rate control, the rhythm control, and anticoagulation. The rate and rhythm control will be done using medications from the Vaughan-Williams classification of antiarrhythmics. And there are two types of doing that. We call that process a cardioversion, where you correct the abnormal rhythm of the heart to the normal rhythm. There are two types of cardioversion. We have the chemical cardioversion, which is by using the medications as I indicated, or what we call the second type will be the electrical cardioversion. And with the electrical cardioversion, the direct current will be used. So we are saying in this case, after the direct current has been used to correct the abnormal rhythm of the heart, the right atrium is unable to contract immediately, hence the absence of the A wave. Then finally, the last cause will be the sinoventricular conduction in hyperkalemia. Now let me explain this to you. When we say sinoventricular conduction, simply means that the sinoatrial node is able to generate impulses, but these impulses do not spread through the atria, and by so doing the atria is unable to contract. But once again, the impulses generated by the sinoatrial node are conducted via routes to the atrioventricular node, and furthermore to the ventricles, where the ventricles will be contracting. And that seeks to depict the fact that there actually exist routes between the sinoatrial node and the atrioventricular node, referred to as the internodal path. Means that there exists a pathway between the two nodes. We call them the internodal routes or the internodal pathways. It seeks to depict that. And why are we saying that hyperkalemia will be the cause? If you look on an ECG, you realize that in hyperkalemia, the P waves are basically becoming smaller and smaller until they disappear. So the same conversion can be used in the jugular venous pressure waveform with regards to the A wave, where the A wave would become smaller and smaller and disappear, meaning that the impulses that are generated from the sinoatrial node do not spread to the atria, and that will make the right atrium not to contract, hence the absence of the A wave. Let's move on and look at the second abnormality of the A wave, and that we'll call it a large A wave, a prominent A wave, a giant A wave, or also referred to as the venous corrigan. So these are all synonyms. The giant, large, prominent, they are all synonyms of the venous corrigan. So when we say venous corrigan or giant A wave or large A wave, simply is a prominent A wave produced as a result of resistance to atrial emptying. Now let's explain that into details. So let's take this as the right atrium, the right ventricle, the inferior vena cava, and the superior vena cava. Now when the right atrium gets filled with blood, what happens? The tricuspid valve is supposed to what? Open, so that the right atrium can empty its content, that's the blood, into the right ventricle. But in a scenario where there's going to be a large or prominent A wave or a venous corrigan, there will be resistance produced against the emptying of the blood from the right atrium. Which resistance can it be? The resistance can come from two categories. What are these two categories? The first one is going to be at the level of the tricuspid valve. And if it's at the level of the tricuspid valve, we can talk about tricuspid stenosis being the reason for the resistance. Because if there's tricuspid stenosis where the opening of the tricuspid valve is so narrow, then the right atrium is going to face a resistance from this narrowing. Hence, it must contract in excess to overcome this resistance. And as it's contracting in excess to overcome this resistance, the amplitude of the A wave, which was formerly like this, will now become like this, telling us that the A wave has become what? Large or prominent or giant. Why? Because there is a resistance against the right atrial emptying. And at the tricuspid level, tricuspid stenosis is one of the causes. Another cause at the tricuspid level could be what? Right atrial tumors. When there are atrial tumors in the right atrium closer to the tricuspid valve, definitely is going to produce a resistance against the right atrial emptying. So at the right atrial level, yes, we have the tricuspid stenosis and we also have the right atrial tumors. The next category of causes is going to be at the level of the right ventricle. And at the level of the right ventricle, remember that the right ventricle empties into the lungs via the pulmonary artery. So if there is an embolus here, it means that the blood that is supposed to empty from the right ventricle into the lungs via the pulmonary artery is going to be obstructed, meaning there is going to be resistance produced here. And if there is a resistance here, then it means the right ventricle will not be able to empty. The right ventricle becomes congested with blood, and as it's congested with blood, it tends to overflow into the right atrium, meaning if the right atrium wants to empty into the right ventricle, it will not be able to what? Empty. Take a bucket, for instance, and put it under the tap and open it. You realize at a point the bucket will what? Be overflowing. Why? Because it is filled. There's no opening for it to what? Exit. That is exactly what we are having here. If the pulmonary artery is blocked by an embolus, then definitely the right ventricle will become filled, become full, and it will start overflowing, and that will produce a resistance against the right atrial emptying. So in that case, acute pulmonary embolism is a cause at the level of the right ventricle. Another cause we can think about is tricuspid regurgitation, where the tricuspid valve is insufficient. And if it is insufficient, it means that during systole, what we are going to witness is that the right ventricle, as it contracts, is supposed to empty via the pulmonary artery, but because there's an opening here, the blood would what? Flow back into the right atrium. Why? Because if you look at the Pascal's law of pressure, which states that pressure exerted at the point is equally distributed in all directions. And if you look at that, once there's an opening and the pressure is being distributed in all directions, as you can see here, any opening that is available, the blood will flow through it. So in that case, that will be producing a resistance to right atrial emptying. So another cause at the right ventricular level will be what? Acute tricuspid regurgitation. Then another one will be if you have the ventricle, the right ventricle is becoming hypertrophied, And why would it become hypertrophied? If the pressure in the pulmonary vessels increase. So we will say that another cause at the level of the right ventricle will be a concentric right ventricular hypertrophy secondary to pulmonary hypertension. A concentric right ventricular hypertrophy secondary to what? Severe pulmonary hypertension. That's what we have here. So those who constitute the causes of a large, a prominent, or a giant A wave, also known as the venous corrigan. I believe we get that. Okay, let's move on to the last abnormality of the A wave, and that is going to be the canon A wave. When we say canon, it simply means that it has become larger. So if you look at the second abnormality, we said a large or prominent or giant A wave. But in this case of the canon A wave, we are looking at what? A very large, a very prominent A wave. When we say canon A wave, let's have a look at this. This is a normal A wave. This become a large A wave, and then this become a canon A wave. So this is the normal A wave, large A wave, and canon A wave. So if we are talking about canon will be the largest of all. So when we say canon A wave, simply it is a very large or a very prominent A wave produced as a result of right atrial contraction against a closed tricuspid valve. That is what we refer to as the canon A wave. Now, what are the causes of the canon A wave? Before we can talk about that, there are two types of canon A wave. We have what we call the regular canon A wave and the irregular canon A wave. And based on that, we will have the respective causes. And what are these causes? When we talk about the canon A wave, do you remember the causes? Remember JIV, that's JIV. And that would go for a junctional rhythm, isorhythmic AV dissociation, and finally ventricular tachycardia, 1:1 retrograde conduction. So that's JIV, junctional rhythm, isorhythmic AV dissociation, and ventricular tachycardia, 1:1 retrograde conduction. Let's talk about the causes of the irregular canon A waves. For the irregular canon A waves, to easily remember, think of what? V to the power 3, C to the power 2. And what are these? We have the first one to be the ventricular tachycardia. The next one, we can talk about ventricular ectopy, where you are having impulses being generated at unusual sites other than the main site in the conduction system of the heart. Then we can also talk about ventricular pacing, also known as a single chamber ventricular pacing, meaning it's going to be just in the right ventricle. Then with the C square, we are thinking of complete heart block, also known as the third degree heart block, where there is complete dissociation between atrial contraction and ventricular contraction, meaning the atria and the ventricles contract on their own accord, not in relation to each other. Then finally, the last cause of the irregular canon A waves, we have what we call the classical atrioventricular dissociation. I believe we've learned something new today. Kindly make sure to subscribe to my channel, like, share, and also recommend to friends. And do not forget to comment the next concept you would like to see on my channel in the commentary section. My name is Dr. Del, and once again, this is Concept in Medicine. Bye-bye.